Hello, I'm Vikas Gupta. I'm a multidisciplinary clinical lead in leukemia and director of Elizabeth and Tony Comper MPN program at the Princess Margaret Cancer Center in Toronto. My academic focus is on myeloproliferative neoplasm, and that's what we're going to talk about today.
Hi, everyone. My name is Sirhan. I'm a hematologist and oncologist in Montreal, Canada. I head the MPN clinic at the Jewish General Hospital, and I'm also the current president of the Canadian MPN group. It's my pleasure to be here today discussing MPNs. Hi, Vikas. I would like to ask you a few questions about MPNs. Can you briefly explain what MPNs are and what are the three main types and how do they differ?
So thank you, Shireen. As the term myeloproliferation indicates, myelo mean bone marrow and proliferation mean excess production. So myeloproliferative neoplasm is a group of family of blood disorder where there is a excessive production of blood cells in the initial phases of the disease. There are three classical myeloproliferative neoplasm: essential thrombocythemia, polycythemia vera, and myelofibrosis. Patients with essential thrombocythemia and polycythemia vera in the later stages of the disease can also develop myelofibrosis. Now, in essential thrombocythemia, there is excessive production of platelets, and patient is at risk of getting blood clots or bleeding complications. In patients with polycythemia vera, there is overproduction of the red cells, and in addition, white cells and platelets can be high also. And in patients with myelofibrosis, there is a scar tissue in the bone marrow. As a result of scar tissue in the bone marrow, blood cell production start taking place in spleen, and spleen start getting bigger. And patients with myelofibrosis also can have significant symptoms related to cytokines or symptoms related to spleen. These symptoms are usually abdominal fullness, pain in the abdomen, dragging sensation in the abdominal area, or symptoms such as fever, night sweats, or weight loss. So, Shireen, how do you explain to your patients the natural history of myeloproliferative neoplasms?
So the natural history is variable. For example, if we start with ET, patients with ET can have a normal life expectancy or near normal life expectancy. And most of the complications for these patients come from having thrombotic complications and sometimes bleeding complications. However, there is a small percentage of patients who can progress from ET to post-ET MF and subsequently to acute leukemia. Polycythemia vera, also there is a significant number of patients who early on in the disease may develop thrombotic complications, and also there is a risk of progression similarly to post-PV myelofibrosis or AML. Patients with myelofibrosis tend to be sicker. Their disease usually is more symptomatic at the beginning. And these patients, depending on certain prognostic factors that we will discuss later, some of them may progress earlier than others. And our focus in treating these patients usually at the beginning is to alleviate their symptoms. And younger, more healthy patients may be eligible for curative treatments such as transplant.
Yeah, you're right. The natural history of myeloproliferative neoplasm can be very variable, and each patient can take own trajectory. As you mentioned that some patients with ET and PV will develop into myelofibrosis in the later stages of the disease, and all three myeloproliferative neoplasm, ET, PV, and myelofibrosis have risk to develop more aggressive type of leukemia, also known as acute myeloid leukemia, which is usually have extremely poor prognosis. Now, in terms of symptom-wise, what are your thoughts on whether symptoms of myelofibrosis patient are different than ET and PV patient? And what are the sort of common symptom your patient present with when you encounter them in or see them in your clinic?
I think one of the most common symptoms to all three of the MPNs is fatigue. And unfortunately, this is one of the most difficult symptoms for us as physicians to be able to manage and help our patients through. And I see that across the MPNs. Some of the symptoms that may be more specific to or more common in one of the MPNs than the other, pruritus, so itching, especially after a shower, is more common in patients with polycythemia vera. Patients with myelofibrosis tend to have more symptoms related to the spleen because it is bigger usually in that disease. So, discomfort on the left side of the abdomen, getting full quickly, pain in the left side of the abdomen. And then patients with myelofibrosis also have more of what are considered the constitutional symptoms. So weight loss, sometimes fever, and night sweats.
I mean, you mentioned about itching symptoms in patients with polycythemia vera, which is common after taking a bath, also sort of, known as aquagenic pruritus. And I often encounter patients with polycythemia vera often have headache, dizziness, in addition to these symptoms. And as you mentioned, that all three type of myeloproliferative neoplasm have increased risk of getting blood clots or cardiovascular event. By cardiovascular event, mean higher risk of getting a heart attack or a stroke.
So, Vikas, what are the most common mutations in MPNs and how do these contribute to the disease?
Yeah, a significant understanding has happened in the last 20 years. So, there are three main MPN driver mutations, and these are JAK2 mutation, MPL, and calreticulin or CalR mutation. JAK2 mutation was first found in patients with MPN, and this mutation is in patients with polycythemia vera. This mutation is present in almost 95% of the patients. And the patient who are negative for a typical JAK2 mutation, majority of those patients will have a mutation called exon 12 mutation, which has similar functional consequences similar to JAK2 mutation. The second mutation found in patients with myeloproliferative neoplasm is MPL mutation. MPL mutation is found mainly in patients with essential thrombocythemia and myelofibrosis and is present in 5 to 10%. And the other MPN driver mutation is calreticulin mutation. Again, this mutation is mainly found in ET and myelofibrosis patient and is present in about 20 to 25% of these patients. Now, although these are different mutations, all three of these mutations are associated with dysregulation of the JAK-STAT pathway, and which results in excessive proliferation of these blood cells in the initial phases of the disease. So, how does a patient with myeloproliferative neoplasm usually come to attention, or what are the diagnostic investigation do you guys usually perform in your clinical setting?
So I think everybody's been getting more blood tests in the last, I would say, in the last decade. And therefore, we've been picking up a lot of patients with MPNs earlier and earlier. I think in the past, patients used to present either with a thrombotic or a bleeding event. However, now many of our patients have an incidental finding on their CBC, either polycythemia or high platelets, or patients with MF may have anemia. So we've been diagnosing patients earlier and earlier. And once these patients come to us, in addition to their blood tests and the mutations that you have mentioned, we do molecular testing for the JAK2, CalR, and MPL. And in most cases, we proceed with a bone marrow biopsy to help us confirm the diagnosis and differentiate between the different types of MPNs. In addition, we also have now availability of next generation sequencing, which tests for other mutations other than the three mutations you mentioned, which we consider to be the driver mutations. We test for other mutations that help us refine the prognosis of our patients, especially those with myelofibrosis. We get a better idea of the prognosis, which helps the patients plan how they're going to cope and live with this chronic illness, and also helps the physicians decide whether this patient, for example, should be referred for a transplant earlier. So we've come a long way in terms of our diagnostic capabilities for our MPN patients.
Yeah, I agree that with easy access of genetic testing, such as testing for MPN driver mutation, JAK2, and calreticulin, we are picking a lot of patients earlier in the disease course. Some of these patients could have missed in the past and sort of present with some complications. So this is a good thing that in majority of parts of Canada, these access to these mutation is sort of readily available, and worldwide also sort of there is increased awareness and access to this testing.